Hello, Dr. Church. Thank you for having
Hi.
me today. We addressed a couple of big topics last time about like the meaning of medicine to you and your road trip until you got to this point. And I think now we're going to talk a little bit about some medical topics. I think the most common thing that we see in our clinic is people complaining about their bottoms, an itchy bottom, a bleeding bottom, or some pain in their bottom. So, what do those things mean to you when a patient comes and says, I have one of these problems?
Um, well, first thing to think about is that these are anal problems, and the anus is a wonderful organ. So when you think
That's
about,
interesting you say that.
what does it have to do, and what can it do? So it can hold the stool when you don't want it to come out, let it out when you want it to come out, um, keep the gas in when you don't want that to come out, let you discriminate gas from liquid from solid, to be polite. Um, it can accommodate small stools, large stools. It can sense there's something in there, it can tell you what sort of thing is in there. It's an amazing organ, but it's often abused. And it's abused because people don't pay good attention to their bowel habit and they don't eat right. So, the ideal bowel function for an anus is to have an empty rectum above it for 95% of the day, and then have a mass movement moving the stool into the rectum. You know that the person knows that there's stool in the rectum. It descends and triggers the anorectal inhibitory reflex, which allows whatever's in the rectum to go down even a little further into the upper anus, and the anus detects what it is. And then the rectum is going to contract to squeeze that stool out, and you have to be in the toilet when that happens to allow it to go easily, just smooth as silk into the toilet. And then the rectum is empty and the anus is resting again, and everything resets. And that's the sort of thing that when before there were cities, when Homo sapiens was living in the bush, um, that was it, because you didn't have to find a toilet. There were leaves everywhere to wipe your bottom if you wanted to. You didn't even need to wipe your bottom because you had number one stool, which is sort of so coherent that it doesn't leave anything dirty behind. You could let the gas go anytime you wanted. No diverticular disease, nothing. It was
Because you had
just
a good diet.
a perfect world for the anus was the bush world, living in the bush. Move into cities and everything goes to hell in a handbasket, because now you get constipated because you're not eating right. There's no time to go to the bathroom. You got to find a toilet. You don't like that toilet. You're going to hold on to it. Anyway, so that leads to anal symptoms. So this is why people come and see us as colorectal surgeons, with things are happening with their bottom. Basically, it's their fault, which means that we can correct a lot of that just by re-educating them about what is good bowel habits. So people tend not to think about their bowel habits as good and bad. They see going to the bathroom as a really unfortunate necessity of life, if they think about it at all. They don't think about it unless it intrudes into their thoughts in a bad way. And they'll put up with symptoms that they have created until they're really bad, because they don't want to go and see you. They don't want anything stuck up there. And they know if you come and see a colorectal surgeon, something is going to happen which they're not going to like.
Some things.
Yes, perhaps several things will happen that they're going to hate. And so, but they're also worried, so if there's some bleeding and if they're sensible people, they'll be worried that there may be something bad going on. But it's surprising what people will put up with in the way of anal itching, wetness, constipation, pain, lumps, tags, all those sort of things, before they come and see you. So you may sometimes, in people that really don't want to see you, you'll see like an end stage anus that looks pretty bad. So anal symptoms are common, and you see a lot of them.
So when you talk, let's say if we started with someone coming to your clinic and saying, I have anal itch, could that be a sign of cancer or could that be just something normal? Like, what is the range of problems that could cause a symptom like that?
Yeah, cancer is certainly a problem, and patients with Paget's and Bowen's can present with itching. That's pretty classical. So the first thing to do um, is to sort out their bowel habit, because Bowen's and Paget's are pretty uncommon, and itching is a common symptom. So it's something to think about. So with any anal condition, the history is important, and at the end of a good history, you should have a good idea of what's going on down there. So the commonest cause of itching is, well, just to back up, your history should be informed by what you know about pathophysiology around the anus in terms of itching. So the commonest sort of itching is non-specific pruritus, which is due to a wetness in the anal skin, which leads to a kind of chronic damage and thickening and mini ulceration in the anal skin, which is itchy. And then patients scratch it, rub it, and it damages the skin a bit more, and it causes the skin to weep, and it gets more wet and more itchy. And so they itch it more, and then it damages it a bit more, and so you get on this merry-go-round of never-ending symptoms. So what's the cause of wetness around the anus? So one of the common causes is prolapsing hemorrhoids, which secrete mucus. Another is just bad anal hygiene. Another is you get like a mild symptom down there, and you put ointment on it, and the ointment makes the skin wet. And so people often treat pruritus with ointments, and it makes patients feel better for 20 minutes, and then it's back to pruritus again. So you're thinking about those things. You're thinking about their bowel habit. You ask them about that. What's their toilet habit? How do they clean themselves? It's unbelievable what some people will do. You know, in general, you can divide people into polishers and not polishers. So, how many pieces of toilet paper do you need? And that relates back to the bowel habit. So, if your stool is kind of sticky, difficult to clean, they may go through 12 pieces of toilet paper per defecation, and the poor skin is really sucking it because of that. On the other hand, you know, as I said, the ideal bowel habit is a nice log that drops out, bloop, and then there's nothing to clean. So maybe one piece of paper just for peace of mind, and that's it. That relates a lot to the nature of the stool, also somewhat to the sphincter strength. So it's the polishers that get into trouble with pruritus, and you can't break people of that habit. You know, they're just fascinated by the anus, but they're also determined to have it as clean as a whistle. They won't put up with even a fraction of brown on the paper, and they say another piece of paper. So you can talk to them about that, but you're not going to change them. So Metamucil to me is good for that because it binds the stool together. It's a normalizer. People think I don't need Metamucil, I'm not constipated. But it's a normalizer. So it'll take hard stool to normal and fragmented stool, which is the issue, back to a coherent stool. And they pass it all at once, and then they don't need to clean like a demon. If people are polishers, you might suggest that they use witch hazel or some sort of medicated wipes. But be careful about having a wet anus. And if they come to you with pruritus, they have to keep, I tell them 2 words, dry and gentle. You've got to have the anus dry, you've got to be gentle, you can't rub it. If you are going to clean it, you pat it. But then getting back to working up a patient with pruritus, they've taken the history, then you have a look. And this is where the cancer issue comes in, because usually you could recognize Paget's or Bowen's disease by looking. And the Paget's kind of look pink patches beside the anus. One of the differentials of that is eczema. And then there is a condition called erythrasma, which is an actual bacterial infection. All of those can cause pruritus. And if you're uncertain, I mean, it's reasonable to get a dermatologist to have a look. But you should be able to recognize those sort of things. And if in doubt, take a biopsy and see what's going on. Yeah, eczema is pretty easy to diagnose, and you treat that with hydrocortisone. But if you do have ointment, you rub it well in. And one of the giveaways is it's generally not completely circumferentially around the anus. There's a patch. Psoriasis can affect that area as well. So, and that's a patch. It's not everywhere, but you look around the patients know if they've got psoriasis.
You mentioned, you were talking about itch a little bit, and then bowel habits. What is an ideal diet and what is an ideal bowel movement? You talked a little bit about it being a log, but what's an ideal diet to lead to that?
Well, let's define the ideal bowel habit. To me, the key thing is not straining. It has to come out easily. And so that's ideal. I don't care if it's big or small, hard or soft. If it comes out easily, that's fine, because then you're not putting any pressure on the anus. You're not encouraging the hemorrhoids to prolapse. You're not encouraging the rectum to prolapse. You're not going to block up the anal glands. Everything is as good as it can be. Now, normally, an easy bowel movement is timing of the urge is key. So if you get the mass movement, you feel the rectum filling up. If you can get to the bathroom within a minute or two, it's just going to slide right on out. The worst in terms of timing is to put it off completely, and then the urge goes away, but your rectum is full of stool. So it's not too long before the urge will come back, but it's never as good because it doesn't come from the descending colon, it just comes from the rectum. And the stool is now harder than it was because the rectum's absorbed some water. And so then you have to strain. You have to strain to get it started, and you have to strain to get it finished. And that's not good. So timing is the key. The other important things that are important are fiber, a good amount of fiber, and a good amount of water to keep the stool well hydrated. Those are important too, but they're like number 3 and number 4 in terms of importance.
And you talked about Metamucil a little bit. How do you advise patients to take it? Do you advise them to start with the 3 tablespoons? Or do you advise them to start with the 2 tablespoons, 1/2? How do they start taking it?
But the myth is that the more fiber, the better. That's one myth, and that's definitely not true. And then another related myth is American Dietetic Association recommends 30 grams of fiber a day. You cannot do that. I mean, that might be the average for the average person, but there are a lot of people out there that would be really bloated on 30 grams of fiber a day, and then there are others that it wouldn't be enough. So I tell the patients that the end point of their diet is what the stool is like. So if they're passing nuggets, then that's not enough fiber. And if they're passing giant poops, 6 or 7 of them a day, that's way too much fiber if they're cramping and bloating. So what I would tell them, the normal stool, I have described it as a policeman's truncheon, would be perfect. That sort of diameter, just sliding out, easy. That's what we want to get to. And I tell them that every patient is different in the amount of fiber that's ideal for them. And then I point out, if your stools are nuggets, then you need more. I tell them that the best way to get fiber is the natural way. So fruits and vegetables, cereals, bran, that sort of stuff, brown bread. And if that doesn't do it, or they don't like eating fiber, then you can go to the artificial bulk formers such as Metamucil. And I usually recommend a teaspoon a day. I have had patients on 3 tablespoons a day. It's not good.
I remember a handful of patients that I've seen this year. they come in, like, they talk about bloating when I'm chatting with them about another problem. Like, how much fiber are you taking? And they're like, 3 tablespoons. I'm like, you're tiny. You, well, no, let's just slow down. Let's go back.
Yeah, not to mention that it's completely wasted.
Yes.
So yeah, a teaspoon a day is fine. But I like to use Metamucil also for patients that have seepage,
Mm-hmm.
because there will be a bit of mucus hanging around the rectum or little fragments of stool from diverticulum. A lot of patients with diverticulosis will pass little nuggets, and it's not their fault, and it's not that they're not eating enough fiber. It's just that the stool gets into the diverticulae and then comes out. So a teaspoon of Metamucil will bind the stool more, prevent that from happening, and stop sort of seepage from a slightly loose anus or hemorrhoidal prolapse by pulling the mucus into the stool, and then you pass it all out together. So that's not for the benefit of bulk, but it is for the benefit of controlling mucus with the fiber. It kind of sucks it in. So you can use Metamucil those two different ways. But when I say Metamucil, all the other
Fiber supplements.
Yeah.
Okay, anal pain. What could cause anal pain?
There's myriad of causes of anal pain. So again, the history is key. So the questions you need to ask are, do you have it all the time or just sometimes? And so all the time pain are things like an abscess or these are the common things, thrombosed hemorrhoid, and just constant. Or perhaps a cancer. Yeah, those are the main things. So intermittent anal pain brought on by a bowel movement, I mean, classically that's a fissure, but it could be some sort of ulcer within the anus. It could be herpes. It's very painful around the anus, but tends to die away when you're not rubbing it. So anything that where you're wiping your bottom implies that the skin is damaged somehow. Other intermittent pains related to posture. So, I mean, again, the classic sitting pain is levatorspasm pain. Standing up, it goes away. Anismus is more constant. I define anismus as a really, really, really tight internal sphincter. So it's spasm, internal sphincter spasm. But it's so tight that the sphincter becomes a little ischemic and is painful all the time. Is it related to a lump or not? So pain related to a lump could be an abscess or a hemorrhoid, basically. I guess a tumor of some variety. And is it associated with any other symptoms? Is it pain and bleeding? Pain and bleeding that is stimulated by a bowel movement is a fissure pretty much all the time. If it's associated with constipation, that's not unusual, because if you have a painful anus, you don't want to use it, so you shut it down. So that could be anything. It's not particularly specific. So once you've asked those sort of questions, have you ever had it before? Have you ever been treated down there? Did something happen? Did you pass a giant stool because your doctor told you to take too much fiber? And then that was sore. So are you under a lot of stress? All of those sort of things. And then you look. But when you're looking, you have this list of things you want to rule out.
Okay, and then that lead us, because you mentioned a little bit anal pain, fissures, and thrombosed hemorrhoids, which both could lead to bleeding. How do you look at or think of anal bleeding?
Well, the first thing is anal bleeding is not normal. It's never normal. So it needs to be checked out.
And is it always cancer?
It's almost never cancer. And I'm sure you've read the 2 papers I wrote on this subject, subdividing rectal bleeding into 4 different categories, and then using my colonoscopy experience to see how common cancer was associated with it. So typical outlet bleeding was defined as bright red on the paper or in the water, not associated with a family history of colon cancer, not associated with any change in your bowel habit. And that did have some cancers associated with it, like 7 out of 400 patients. but they were all low cancers, all distal cancers. So even bright red bleeding can be associated with cancer. Suspicious bleeding, which I define as dark or clots in or on the stool, or any sort of bleeding associated with a family history of colon cancer, had a lot more cancers. And they were mostly in the rectum and sigmoid, but they could go around the left side, the right side. So it meant colonoscopy was essential. For bright red outlet bleeding, you could get away with the flexible sigmoidoscopy. And then I added the two, occult bleeding, which had the highest incidence of cancers, and most of them are right side. And then hemorrhage, which was, I defined it as being admitted to hospital for the bleeding. A few cancers and a weird collection like ischemic colitis, radiation proctitis, diverticular bleeding, etc., etc.
Moving now to different symptoms, talking about constipation and diarrhea, because those are two words that people use all the time and they mean something different to every patient. What's the difference between constipation and diarrhea?
Well, you're right. A lot of people mean different things by constipation, for example. So it could be the stools are too small, it could be that the stools are too hard, it could be usually the stools don't come often enough, or it could be that they come often and you're straining till you're red in the face to get rid of them. So all of those different things could be what the patient's meaning. So the first thing is to sort out, well, what do you mean by constipation? And they may say, well, I only go every second day. And then you say, well, it's normal. You're not constipated. Or they could say, I go every day, but I sit there for 3 hours to get it out. And I'm putting my finger in to pull it out. And you say, well, sounds like your pelvic floor is a bit spastic. Or it could be, well, I don't go until every 6 weeks. And then you say, well, it sounds like maybe a bit of colonic inertia is going on. So those are the ridiculous examples of that. But the first thing is to sort out what the patient's mean by constipation. It's the same with diarrhea, although it's a little bit different. So most people think of diarrhea as liquid stool, but a lot of patients refer to urgency as diarrhea. And there's a big difference. So you can have a patient with liquid stool, but they can control it fine. And so it's also the result of a comparison with their normal. So normal solid stool, now all of a sudden it's liquid, but they're controlling it. Or you can have a patient that has kind of irregular irritable bowel habits, and then all of a sudden they've got to get to the bathroom in 30 seconds, otherwise they're going to poop their pants. And it can be semi-solid, but they're going to call that diarrhea. So the first thing is to sort out, is it liquid or solid? Is it urgent or is it non-urgent? Is it related to food? Like if you starve yourself, are you still going to get it? And have you been to Mexico lately?
So, I mean, those could mean so many things for people. When someone says they have constipation, could that be related to the food they're eating? Or is it always a problem they have with their colon or rectum or anus?
I think the commonest cause of constipation is a bad diet. Yes, not enough roughage, for sure. I divide the constipation into the sort of, quote, normal constipation that affects so many people, which you can correct by correcting diet. And then the serious constipation. Other things that we need to think about that commonly affects bowel habit is medications. So patients that have been fine and then they just get started on a couple of cardiac drugs or a psychologic drug, then they get constipated as a result of the drug. So that's very important to sort out. And then patients that get older, the colon tends to slow down and gets longer. So somebody that wasn't constipated when they're 30, when they're 60, may well be constipated just as a result of an age change in the way the colon works. Patients that have surgeries, especially pelvic surgeries, can end up being constipated. So there are a lot of other factors that sort of impinge on the diagnosis. So it's important to work that out, but it boils down to, in terms of serious constipation, is it a colon problem, like colonic inertia, for whatever reason, or is it a pelvic floor defecation problem, again, for whatever reason.
And then another set of symptoms that we hear about is like, or at least we get consulted about in the hospital a lot, are people with nausea, vomiting, and abdominal pain. Are those always stomach-related problems, or they could be related to the colon or the rectum?
Well, certainly pain is very, just as a word, is very non-specific. And pain could be coming from the abdominal wall, and frequently is. So anyone with incisions in the abdominal wall, or manipulation of it, or even straining and pulling a muscle and stuff, can get abdominal pain. So you have to look for bowel-related symptoms that would relate the pain to a bowel movement. Just for example, like, is the pain worse after eating, or before eating, or after pooping, or before pooping? Is it relieved by pooping? Is it relieved by eating? And then you build up a picture. You also know that colicky pain is generally related to some sort of hollow viscus, and constant pain is not. Constant pain may mean that something has happened and it's gone from obstruction to strangulation. So it's knowing the pathophysiology of what could be going on and what that would do to your pain levels. Nausea is a little different, because they're the whole host of drugs that cause nausea. I mean, there are so many causes of nausea. Brain tumors can cause nausea. But, I mean, it's a classical sign of obstruction. So if you have nausea and you have colicky abdominal pain, and the person's just had an abdominal surgery, then, I mean, it sounds like an adhesion obstruction to me. So you listen for the bowel sounds. You know, this is one of the keys. You don't go off and get a CT scan straight away. So nausea is difficult. Nausea, pain, and
Vomiting.
Yes, vomiting is similar. It's a little easier, I think, because it's a lot more. Functional vomiting is not that common. So usually there is something going on to block the stomach and to cause the throw up.
You mentioned something about listening to bowel sounds. How do you do that, with your ear?
No.
What do you use?
A stethoscope.
What is that?
It's the thing that cardiologists use to listen to.
Yeah, I thought surgeons don't use that. So tell me, let's talk about bowel sounds. It's an important point that I think most surgeons ignore at this point because of a paper that did not correlate bowel sounds with bowel obstructions or outcomes. So tell me a little bit about listening to bowel sounds.
Can I tell you a little bit about papers that say that bowel sounds are not important? It's rubbish. A rubbish paper. So we need to be sensible about this. So typically bowel sounds sound like tinkling, like water dropping in a cave. But I mean, that's the obvious sort of bowel sounds. You can just listen to the general activity, and you can tell when the bowel is upset, that it's hyperactive. So hyperactive bowel sounds is something to know about, you know, and bowel sounds are in a clinical setting. So it's not like you couldn't do an exam for listening to bowel sounds and play a series of tapes of various conditions. You have to be there by the patient. You have to feel the abdomen. Is it distended? Is it tender? Is it tympanitic? So the bowel sounds as well as percussion. I bet very few people percuss abdomens these days. Where is it in the abdomen that the distension is? What's happening with the patient's bowel movements? What's the clinical context? So absence of bowel sounds is a good evidence to me of an ileus. But you have to listen for a couple of minutes. And then you might get the odd tinkle that tells you that this is an obstruction, that the bowel is sort of given up. So it looks like an ileus. And then there are other things that you can hear as well as bowel sounds. Listen for bruits. You know, that's an important finding in some patients with abdominal pain, that you have no idea what it is, and they have a stenosis in their SMA, and you can hear the bruit if you listen for it.